Love that. Okay, so thanks for coming back from the break. My name's Farrah Daly. I'm a neurologist and palliative care specialist in Northern Virginia. My task today is to speak about preferences and goals for life-sustaining therapy across the illness journey. I have no financial disclosures. I will call out some abbreviations that I will be using in my slides. LST is life-sustaining therapy. WLST is withdrawal of life-sustaining therapy. PLI, or sometimes I may use PLNI, person living with illness or person living with neurologic illness, and HCP, healthcare professional. Hopefully I will stick with this terminology throughout. The official objectives of my time are to describe the spectrum of life-sustaining therapy decisions that people with neurologic illness may face, to describe the components of shared decision-making, and to list factors that may influence a shared decision-making conversation or series of conversations. And I will tell you, in addition to these specific things, really my overriding goal is to remind us all of just how complex and nuanced and layered these situations are. And I will not be providing you with any solutions. So I just want to set those expectations right from the outset that I'm going to be reminding us all of how difficult it is and why work on solutions is important. I will remind you that there are 2 posters outside that are trying to figure out how to improve discussions about life-sustaining therapy, so you should be sure to check those out. And after I speak, Professor Christina Faull from the UK will be speaking about her experience and research trying to improve the situation in her particular practice environment. I will also like to call out some of the biases that I speak from. And I practice in the United States, where initiation of and cessation of life-sustaining therapy are both considered ethically acceptable and legal. I trained, really starting with medical school, my training is from 1999 till 2009. And I was taught to have emotional armor when I was taught to have conversations about making decisions. That was part of my education, to separate myself from the conversation and to have emotional armor. So that's the landscape of my training. I was taught to change the subject if people talked about spiritual issues when I was having a difficult conversation. I mean, that was, I think it's easy for us to forget and to think about like how wrong that is when we hear that happens. And it's easy to forget that many of us, and like I'm getting older, but I'm not so old, and it's not that distant in the past when we were specifically taught to do it other ways. So we shouldn't be surprised that this is sometimes an uphill battle. And I'll also say my only experience in life-sustaining therapy decisions is from the professional side. I have not experienced this personally, and I'm sure that there are things that I'm missing that I wouldn't be missing had I had this personal experience. Life-sustaining therapy is a treatment without which life would end with a high probability within a foreseeable period of time. That's an official definition. Examples of life-sustaining therapies that we speak about commonly are mechanical ventilation and artificial nutrition and hydration. I want to call attention to that people with neurologic illness may also have very similar feelings and situations regarding whether a treatment is sustaining life when they're thinking about whether or not they would use antibiotics the next time there is an infection that's a complication of their illness. It's a very similar conversation. It may not feel as immediate, but the structure and content are a lot the same or a lot parallel. Or if a family is making a decision that they are not going to transfer their family member to a hospital setting for more intensive therapy the next time an illness happens. In neurologic illness, when we initiate or are talking about life-sustaining therapy, it's often a mix of symptom mitigation and life prolongation that are intertwined. And so it's a little different when we're talking about the acute care setting, people who are in neurointensive care after stroke or TBI or traumatic brain injury. There, the focus really might be, are we prolonging life to see how things will go? But if we're speaking about life-sustaining therapy in ALS or in a chronic progressive neurologic illness, we are often initiating these therapies to mitigate symptoms. So for example, artificial nutrition might be used to reverse weight loss or to remove the stress that is focused around eating or getting a certain calorie content, or in hopes to improve fatigue. And that it also may prolong a person's life is a secondary effect, which may or may not be something that a person desires. Similarly, non-invasive or invasive ventilation is generally being initiated in the chronic progressive situation because of an intention to reduce shortness of breath and to improve comfort and quality of life in a way that spares or delays the need for medication use to get the same effect. And again, whether that therapy also prolongs life may be a secondary effect, which may be desired or not desired. This is a flow or process of how things may progress regarding life-sustaining therapies. When an illness is quickly progressive or chronically progressive, there's a period of anticipation that the therapy may be needed. And there's opportunity for education and layers of discussion and really exploring goals and values and changing decisions over time. A person with a sudden or acute neurologic illness, of course, they enter the flow right at the decision point, and they do not have the benefit of all of those layers, which we could potentially take advantage of in other situations. In theory, once a life-sustaining therapy is initiated, it's important to maintain a cycle of continuous evaluation to see if that therapy is still serving a person's primary goals. And in the North America and Western Europe, where withdrawing life-sustaining therapy is considered acceptable, then if the therapy is no longer meeting a person's goals, then there should be a conversation to stop it. And I also want to say that it's easy to forget that in any discussion about initiating a life-sustaining therapy, there should also be at least a little bit of setting the stage for the possibility that that therapy is going to be stopped in the future. And it is too common, I think, for people to get started on a life-sustaining therapy as potentially a time-limited trial or as an intervention for symptoms and then just left without follow-up, or a person transfers to a different care setting, and there's not an explicit process for that therapy to be reevaluated. So in theory, that cycle is always happening, and if you're in a conversation about initiating therapy, it's important to think about and try to make some arrangements for who and how is that follow-up going to happen. It's an oxymoron to say simple and life-sustaining therapy in the same sentence, but this is kind of a simple framework, a stripped-down framework for what process we actually go through. It's important to first determine who is the decision maker. In neurologic illness, frequently it's going to be a surrogate decision maker rather than the person living with illness, but not always the case. Then to define the goals of treatment by really exploring the values and beliefs of the person who is ill. Evaluate whether their goals are achievable with the therapy, and then to reanalyze the potential burdens and potential benefits. And this is an example of some of the potential burdens or benefits that we might talk about with artificial nutrition. People may hope for improved energy. They may hope for decreased stress around eating. They may hope for the ability to satisfy hunger at a time when swallowing is just too labor-intensive and difficult, but they still have an appetite. But on the downside, there may also be an increased medicalization of the body. There is a risk of complications. Sometimes people think they're going to have a simple procedure, and then they lose ground that they never regained from having had that procedure. And there is potentially an increased burden of work for whichever person is going to be actually cleaning and caring for and putting the artificial nutrition into the tube. And I think it's very important to recognize that sometimes in our efforts to focus on being hopeful and to focus on quality of life improvements, that we can have a tendency to focus our discussions on the benefits and the elements that are highlighted in green, and encouraging people to pursue these things. And there can be a relative lack of attention to the potential burdens. And maybe this doesn't happen as much for those of us that are palliative specialists, but it certainly is happening in the typical outpatient environment, I would say. And it's important to explore why that is. I think it's important to explore that in most of the patient-directed education resources that are available, you can find actually, for example, for gastric tubes and artificial nutrition in ALS, if you look at the available patient information, you can find a lot about the quality of life improvements of artificial nutrition in ALS. But you really have to work hard to find information about what the downsides might be. And so we have to make space to talk about the downsides as well, in the context of also keeping the hope so that people can find the balance that's right for them. So how do people make decisions anyway? Well, in theory, people gather information from all around them to create their beliefs. They then weigh those beliefs in the context of their values or their relative importance they place on different elements of life, and then they make a choice or a decision. The things in decision science that are noted as making a decision difficult are having complex options, high stakes to the outcomes, uncertainties, time pressures, emotional content, multiple stakeholders, or conflicting information about what might happen. So I think it's easy to see that when we're in a medical situation, we are checking all of these boxes. These decisions are the most difficult decisions that face people. And it's our job to help. So right now we are developing, and a lot of people within the INPCS and some of the people in this room working on developing and improving the process of shared decision making, which is growing out of the process of informed consent, which again, when I trained, informed consent was really the focus, and goals of care discussions were really taught as, or intervention discussions were really taught as cold, clinical, primarily legal protection, and really a separation of the human elements from it. In informed consent, the healthcare professional provides adequate information. The person living with illness is free from coercion, and the person living with illness has the capacity to consent or to refuse the intervention. Shared decision-making expands upon that and makes it more of a give and take, in that the healthcare professional provides information, judgment, reasoning, recommendations, and experience. The person living with illness provides information about their values and their goals, and a discussion between them creates a best fit balance of the medical situation and what's important to the person living with illness. So it's all, again, it's pretty straightforward, right? There's two people exchanging information, you come up with a decision. But actually there's all this other stuff going on also at the time that the conversations are happening. So first, resources that are available in a community are going to have a significant impact on these conversations. If you are living in a resource-rich area, then maybe you have 2 or 3 different options to choose from. If you are living in an area where a resource is not available, well, then there is not going to be a choice to make in that regard. As an example, in the United States, there's 7 times more intensive care unit beds than in the United Kingdom. And though acute hospitalization rates per capita are similar, the ICU usage in the United States is much higher. Now, that's not necessarily only because of the resources, but it's a component that factors in. The illness is also adding complexity to the conversation. One element is the pace of the illness, which puts a giant ticking clock on the conversation. Starting with the sudden and acute, obviously, They don't have time to be familiar with the situation before it. They're trying to gather and learn information at the same time that everything is emotional and there's significant overwhelm. In a quickly progressive illness, people are making decisions maybe when diagnostic uncertainty is still at play, or maybe by the time that they have a diagnosis, their illness has progressed and they're still trying to make sense of it, but now they're immediately faced with a decision about life-sustaining therapy. And families have said to me, by the time we had a diagnosis of ALS, for example, the horse was out of the barn and we spent the rest of the time we had trying to catch up to it. In a chronic progressive illness, there's lots of time to prepare and learn and have conversation in layers, and all those things are good. But there is the added complexity of shifting feelings and ideas about what is an acceptable quality of life. There are also shifting relationships and responsibilities that family caregivers who may ultimately become surrogate decision makers are feeling. I recently had a family say to me that they knew intellectually that their spouse, when their spouse was living their best active life, that they know what they would have felt about the situation. However, because of the nature of their very slow and progressive illness, they had stopped feeling like it was a spouse relationship maybe 10 years prior to facing this decision. And this spouse actually described to me that they felt more like a parent now. And they felt more the need to nurture in that way rather than as a partner. And they were really able to describe how that gave them a lot of conflicting feelings about how the decisions that they were making. Other illness factors, this is content I just swiped from Roop's slide yesterday and added it into my presentation. Illness factors in neurology that make things more complex are that cognitive impairment is common, there's increased reliance on surrogate decision makers. Even when there's not increased reliance on surrogate decision makers, there is difficulty communicating. And of course, there's prognostic uncertainty. These are themes we've been talking about already. Now, we've talked about the environment and community factors. We've talked about the illness factors. Now, there's more about the people factors. So it's not a surprise. No one is surprised to think about how the person living with illness brings to the table their own coping mechanisms, their own communication styles or skills, as well as their worldview of what's important and what not, and the meaning of life. And they also bring their experiences, their prior experiences with the healthcare system, either as an individual or as a community. That doesn't surprise anyone. And it also doesn't surprise anyone that the healthcare professional involved might have different levels of training or expertise, or they might have a different set of communication skills. They might be a palliative provider, or they may not be. But also, the healthcare professionals' coping skills and communication style and worldview and experience with the healthcare system is also going to have an impact on the conversation. Just some examples of these factors. You know, I have these factors which are related to race and socioeconomic status listed as a person factor. I want to acknowledge that you could put these under the environment community factor as well, potentially. And I don't want to get hung up on that, but thinking about how if a community of people has had a long history of not adequate trust or not feeling like the healthcare system might be working in their best interests, then that is going to change the dynamic of a conversation like this. And we heard a bit about racial differences in care yesterday, which may be preferences or maybe not. This study showed that Black decedents who had dementia and Parkinson's disease were more likely to have placed for artificial nutrition within the last year of life, as well as other things that are defined as low-value care by the Choosing Wisely campaign. In addition, people from lower neighborhood socioeconomic status, this one is also a US-based study from New York City, had less withdrawal of life-sustaining therapy after intracranial hemorrhage, meaning they had more initiation and continuation of life-sustaining therapy, which dovetails with the data we heard yesterday about people having lower mortality but increased disability post-stroke, potentially. How about this one for the healthcare professional? The frequency of withholding or withdrawing life-sustaining therapy in 37 ICUs across 17 European countries varied by the religion of the physician. This is substantial variability found between world regions, countries, and individual ICUs within a country, and between individual intensivists within one ICU. Then think about the environment that's surrounding this conversation. The legal environment, the cultural norms, it's all having an impact. Dominant principles of medical ethics in North America and Western Europe tend to favor autonomy as the priority. The person is expert in their own goals, values, and quality of life, and that overrides many other principles, as well as the principles of beneficence and non-maleficence and justice, but really autonomy and individual rights, and that tends to be our dominant focus in the way we're thinking about these conversations now. Also, in North America and in Western Europe, we talk about withholding and withdrawing life-sustaining therapy as being ethically equivalent. And just fleshing that out a little bit, if you parse this from an ethics perspective, withholding or not initiating life-sustaining therapy, in that situation, death is expected due to the underlying disease. And the intention of the healthcare professional is to allow a natural death and honor the autonomy of the person who is affected. And if you separate out the consequences and intentions, when you're withdrawing life-sustaining therapy, the consequences and intentions are the same. Therefore, these things are ethically equivalent. But do they feel the same? Do they feel the same for families? Do they feel the same for us? Think about times when you have been involved in a conversation about starting or not starting mechanical ventilation, but think about a time when you've been at someone's bedside talking about removing the mechanical ventilation and how different those feel. And I want to acknowledge that we can't take for granted that these principles are the same everywhere. So anybody who has practiced in Israel or Japan in recent years, if this is wrong, please correct me, because I'm going on what I can find in literature and online. And but at least as recently as 2019 and 2020, in Japan and Israel, withdrawing life-sustaining therapy is not supported legally and is not considered acceptable. And these are resource-rich areas with high capabilities from a technology perspective and thought leadership, and but it's not the same. So we can't take it for granted that it's the same everywhere. And it wasn't the same here. This is, I mean, in the context of human history, these ideas are relatively fresh. Stopping ventilation in the United States was not supported by the law or court system until 1976, 1 year before I was born. And actually, so I just want to say that means that a lot of the people that we take care of have lived a significant portion of their lives at a time when it was not legal. So if you sit down with somebody and you say, it's fine, like, they may not feel that way. And these things also change as technology changes. So if you might have had a conversation about someone starting a mechanical ventilation when it meant being pretty much confined to bed and being attached to a large machine that's intrusive and noisy, that's different than if you're talking about someone wearing a somewhat less intrusive nasal mask, carrying their ventilator around with them and playing the piano. So as technology changes and those things advance and get better, these conversations are also going to change, and they have to keep up and evolve with the different capabilities of the healthcare system. So, again, my role was to just remind everyone how complex this is, and that when we're thinking about these situations, there's so much more that's having an effect that we cannot necessarily understand it all in one go, and we never should think we can. We're just always trying to get better. I don't have time for this, so I will just tease you with the idea that people in this community are doing work to try to make these situations better. I mentioned the 2 posters that are outside, and keep doing the good work, I guess. That's what I will say there. I am actually going to skip this, and I am going to say that just from my own personal experiences, these were 2 times when I felt like I got conversations right with people talking about life-sustaining therapy. And one person said, "You helped me to understand myself." And another person said, "Thank you for talking with me, not as a doctor talking to a patient, but as a human being talking with another human being." And I want to say that in these 2 situations, one of these people made a decision that was consistent with my own internal beliefs and what I felt like I would have done in that situation. And one of them was 100% different. And we're not going to take questions for me, but Professor Faull is going to speak about her specific experiences and her excellent research in the United Kingdom. So I'm going to switch over the slides. That's my job. And Christina, I'm going to be advancing the slides for you. And we might have to. You can't hear me anymore. That's okay. Go ahead.
Can you hear me now or not?
Social workers,
Well
remember? Yeah. Superheroes, guys. Got it?
Good. And have you got some slides up?
Okay, slides. Your financial disclosure is up right now.
Okay, that's great, because I can't. Oh, thank you for zooming out. I might be able to see if you go that way. Lovely. Thank you so much. Okay. So I have received funding for my work through the period that I've done this from the Motor Neurone Disease Association, which is a charity, National Institute for Health Research, which is a government-funded research, Stonygate Trust, which is a charity, and Laurel's Hospice, which is where I work. So I'm a consultant in palliative medicine in the UK. I'm based in an independent charitable hospice, which is an organisation that provides inpatient, community, outpatient care. And I've spent more than 12 years researching in motor neurone disease. And I'm going to talk today about work related to assisted ventilation, and particularly conversations about its withdrawal. So these facts on here will be very familiar to everyone in the audience, I'm sure. We're nationally, internationally quite unclear about the number of patients that choose to use assisted ventilation, but it probably is around 70% that at least give it a try. We don't know what percentage of people persist with it and continue to a point where they're highly dependent on it. What we do know is that the functional status of people, their ability to do things, continues to deteriorate despite that ventilation support, and that this functional deterioration will affect their speech and either their cognitive capacity or their communication capacity for making decisions. Both of those things will be lost as their illness continues. And these are quite uncomfortable facts. And sometimes we don't share them enough with patients and their families, particularly maybe at the point where we're considering the decision with them to start ventilation. And there is a bit of a dance that goes on between the professionals and the patients and families as to who's going to mention the future, who's going to introduce the idea of things getting worse in the future, and maybe it's a good time to start conversations about that. So things can happen very much by default, because I don't know about you, but my experience is that motor neuron disease, or ALS, is such an illness that puts professionals in a position where they feel helpless. So providing something that can make people's symptoms better, can make them have a longer time to live, can feel a very important thing to offer. And then to set the context of how things may deteriorate in the future can detract from that, so can be avoided in conversations. And therefore, the default of carrying on with the ventilation can happen and put people in a situation where they may choose to take it off themselves and not tell anyone about it, or not put it back on. They may seek, in this country, it would be a journey to Switzerland for assisted dying, or it may be in the US in areas that can provide that. They can certainly feel that they're fighting a battle about their future decisions on their own, and therefore can encounter very poor physical and psychological symptom management. So if you could put the next slide on, please. So in the UK, as Farrah has said, is so in the US as well, that in law, a refusal of a medical treatment, and certainly assisted ventilation is a medical treatment, by a patient who has capacity must be respected and complied with. Next slide, please. To continue that treatment actually constitutes an offence, which in this country is called battery. Don't think anyone has ever been taken to court about battery, but it's there in legal statute. And a patient can refuse in advance, by writing an advance decision to refuse treatment, which must be enacted at a time when they no longer have capacity for decision, which in ALS is quite often when people have lost the ability to communicate their decision. Next slide, please. So our primary research was in 2013-14. And my personal journey in this was that I undertook a ventilation conversation with a patient to withdraw their ventilation at their request, and then carry that out. And it was the most emotionally, practically, and ethically complex situation, an impactful situation that I had encountered. I'd been a consultant for 20 years, and suddenly I was really hit by this. And I thought, well, maybe it's just me. And the research that I then carried out to start with was to see, is this just me? Or does everybody find this difficult? And to a certain extent, I was reassured that everybody finds this difficult. Particularly the emotional impact on us as professionals was really different to any other scenario. To a certain extent, because certainly this patient, this sort of patient zero for me, was sitting there doing the Sudoku, having an intellectual conversation with me about withdrawal of treatment, saying that's what he wanted, and the next day he was dead. And that was quite a different situation to anything else I'd encountered in palliative care at that time. And I did more research to see what happened nationally across the country, and particularly to look at family experience, bereaved family experiences. And I found the most harrowing stories about what family had encountered. So we developed from that the guidance under the auspices of the Association for Palliative Medicine to set out the legal context for professionals and to set out standards, and also to develop a database for which we now have nearly 100 people in our database where this has been carried out so we can learn as much as possible. And within the guidance, as on the slide now, there are a series of standards. I'm going to focus particularly on this first standard, which is when ventilation is being considered, that people should be offered the opportunity to have a conversation to make sure that you've got some sort of informed consent, that they understand it's a treatment, that they can choose to stop it at any time. And they should certainly be in no doubt that it is legal to stop it in the UK, in the US, but as Farrah has mentioned, perhaps not in all countries. And that the healthcare team will support them both in stopping that, but also in managing their symptoms in other ways. And you can see the other standards, which we won't be focusing on today, that we've laid out in this guidance. Next slide, please. So we've done further research with colleagues in Nottingham to look at how people go about thinking about their future, and as their illness progresses, how they might think about what to do with their assisted ventilation. And this was in interviews across the UK with patients and family and bereaved family. And we found that there were 4 ways generally that people look at this decision making. So probably the commonest is a reluctance to think about it at all, that people want to live for the day and not to think about the future. That they may do some selective preparation of things for the future, which tends to hinge around wills and conversations, but not about their health, not about escalation of treatment decisions. There seems to be something about the timeliness of the discussion, which may be, I've just had a chest infection, I got through it, I'm not sure that I want to go through that again. So a timely discussion triggered by an event, or it could be a much more personal event, such as someone else in the family being unwell, or it may be that the family is beginning to feel, to the patient, quite burdened by what's going on. So it can be a number of triggers to make the timeliness right, that they're ready to hear it. And a few want to be very proactive, in control, almost from the get-go, are telling you exactly what they want to do in certain circumstances. But we did also find that a significant proportion of the people who participate lacked any clear understanding of what dying would be like on the ventilator, without the ventilator, what their options were. So there was clearly still an awful lot of importance of us taking the responsibility of discussions. And in those discussions, we've got to balance hope and reality. And this next slide, please, talks about how we might endeavour to do that. As I say, it's so important that people know it's their right to stop this, and that we'll help them in a different way. This should be introduced before they decide whether to use the assisted ventilation or not. And actively, and Farrah talked about the ongoing cycle of having the conversation about, is it still right for you as treatment persists? And the next slide, please. Some people may want to talk through actual scenarios of how it might happen. And that's feeling our way very much, isn't it, about the level of detail that people want to know about exactly what happens as someone dies. That's in generality in palliative care, but dying on a ventilator involves the scenario that if they persist until they have died with the ventilation, then the chest may continue to go up and down with the ventilator, even though the heart has stopped. Some people may want, and certainly that is right at the end, and a really important point of clarity. There are changes in colour that happen. How much of that is important to share with people so that they are forewarned rather than shocked? And then promoting the concept of advanced care planning, which still is seldom used effectively in the UK. I think it may be different in the US, but certainly in the UK, it's an ideology that is seldom put into place effectively. But those conversations are so important for at least us as clinicians to write down the impression that we have about what people's preferences would be. And if they want to write an advanced decision, then helping them to do that, or appoint an attorney that's legally responsible and accountable for those decisions. And then assessing capacity at each point. And then next slide, please. So certainly doctors in training and nurses particularly benefit from having scripts that can help inform and develop their practice. So less of this is what you need to do, to moving in education to this is how you might actually do that. So obviously people have their own conversational style and the words may not be, and the phraseology may not be right, but an example script is extremely helpful to many people in learning how to have these sort of conversations. And I think the serious illness guide that you developed in the US is a fantastic supplement to that. And then we're offering within the guidance some elements of conversations about how you might introduce at the beginning, you can stop this in the future. Next slide, please. Other tools for learning and developing our education that you may have come across is work that we've done locally, actually, where consultations between experts, clinicians, so consultants in palliative medicine and patients, real consultations where they're analysed using conversation analysis. And that team of research experts looked at the way this concept of broaching dying, talking to people about the future, talking to the people about eliciting their preferences about what to do in the future. And some people, that doesn't take much to get them to talk about it. Others, it takes a lot of technique to help them open that conversation with you. And there are some papers on the left-hand side here that you might be interested in, and particularly for that latter group who are quite reluctant. The use of asking them about what is the health professional talked to you about in the past, what's your doctor talked to you about in the past, as a way of opening that up. There's a blog here from a resource called Real Talk, which some of you may have come across, but is certainly available to colleagues internationally to look at, which is taking those consultations on a number of topics. This one is just on broaching dying, but there are another number of areas about empathy, about addressing the question of how long have I got, which may be useful to you. And next slide, please. And in terms of opening up these conversations for the reluctant, the kind of skill set that seems to be evident is initially a kind of fishing question. Can I ask you what your greatest concern is? but they tend to not elicit any real focused answers. People are reluctant to talk about things. It's not on their agenda, but it's great for those who want to be in control. Say, yes, doctor, I just want to ask you how long I've got and when you're going to stop this ventilation. But if that's not what they really feel able to bring to the fore, then there are other techniques that are needed to be developed. And next slide, please. So hypothetical questions seems to be a technique that is very strong in doing that, because it's quite difficult for people to resist giving you some sort of answer. It's difficult for them to deflect, but they could still say, like a teenager, well, I don't know, when they do, but they don't say it yet. But it is another sort of layer of people being able to say, well, I suppose if you're asking me what I would hypothetically do, then I'll do this. Just supposing. Just supposing you've got another chest infection, what do you think you would like us to do about that? It just takes some of the emotional, in-your-face reality out of it. And the next slide, please. Some of the things that you need to develop, either help others to develop in their communication skill set, is linking questions to things that patients have said before. So you said initially, Michael didn't have any concerns, but he's feeling funny again. Is that a worry? So linking back, linking even to something that you've said. I said earlier that I'm a little concerned about how you are at the moment. Would you be open to saying more about that, discussing more? And framing a difficult issue as a universal or general. One of the things that we've found is that people generally think like this. Is that you? Again, it takes some of the emotional by generalizing it. And next slide, please. And then in the skill set, obviously there are non-verbal skills to be developed. Hesitant talk is quite useful, as I'm doing now, and that's partly feedback to me. But hesitant talk can be very powerful, and touching people at an appropriate time can convey empathy, sensitivity, that you're with them in this. And silence, which is often the most difficult skill I find for trainee doctors and nurses to develop, not to fill the gap of a place where you've asked a difficult, sensitive conversation and the patient waits and waits. It's very difficult for people to learn that, but it's an extremely powerful tool, as I'm sure you well know. So next slide, please. One element that I think you've had some discussion earlier on in the day, and Farrah, you alluded to it in ICU consultants of different faiths and beliefs having an influence on withdrawal of treatment, but also in how people make decisions. So our values and beliefs can be seen to a very small extent, the iceberg above the surface, by others, but most of them are hidden from public gaze, and they can affect all sorts of things about in palliative care, where we might choose to die, who we might choose to have with us, what duties we need to perform before we die, at the time of death, what our family values are about who needs to make the decision with us or for us, whether we're burdening people or whether it's their duty, our dependence on others, our dignity and our pain and suffering are all values and beliefs that we understand about ourselves and those who are our tribe, but we may not foresee about others, and we may need to try and find that out. So next slide, please. And navigating that in communication skills is quite sensitive, because we feel as if we should know, as if we're being intrusive, as if we're being rude, and at worst we might feel that we're being racist by asking people about their beliefs, about the way that they live their lives. So how do we do this without our own anxiety about being in that dimension of personalizing care for people? We need to understand what people's construct of a good death is. Is it a social one, a health one, or indeed a spiritual one? So is the most important thing that we say that this person in front of us is unable to say the Shahada as they died, or is it about not being in pain and having family there? The dignity question developed by Harvey Chofnoff is really helpful sometimes. And in cultural sensitivity models, the authentic curiosity as a concept can be extremely helpful in helping people to overcome that anxiety about overstepping. How are we polite, but showing that we want to get it right for people? So I don't want to overstep, but it would really help me to understand more about you. I don't know much about your religion. Could you help me know what it is and what it means for you? So I think on the subject of the art and science of practice of this, I'm going to leave that there. I have a few slides on data that we have about withdrawing of ventilation, which is very much on the physical elements of it, but I'll leave it there because that's not really the subject for today, and I'm sure we're way out of time. So we'll stop the slides there, thank you.
Don't go too far away. Oh, thank you so much, Christina, for hanging in there, and then with that excellent presentation after all the difficulties. And thank you to holding the phone up to the microphone. Social workers are superstars and problem solve in ways we could never imagine. So we are like well beyond time, but do you want to just take try to do a few questions? It's the business meeting and lunch right now, is that right? So we're already borrowing 10 minutes from the business meeting and lunch, and we could borrow another 1 minute if anybody wants to really open up. That's right, you had a question before?
First of all, thanks, Arden. We appreciate you. Yeah, let me get my card real quick so I can keep this brief. All right. Yeah, so my name is Randy LeBlanc. I'm a Parkinson's patient, 19 years with Parkinson's, and I also went through prostate cancer along the way. You know, you get one serious disease, you think that's it, but it's not necessarily. Mm-hmm. So your points, just to add to your points about who gets good care. You know, we in Baton Rouge area, I'm from Baton Rouge, Louisiana. We have a advocacy group that we formed to go out into North Baton Rouge and set up support group. We have funds for that, and we have set up a support group for the north area of the city, which is 95% African American. And we actually have a meeting this Thursday to start organizing that. But if you look at the levels of care, first, prostate cancer, the National Comprehensive Cancer guidelines for treatment for prostate cancer, it varies widely. And it depends on what your income is, ability to pay. And if you're at the lowest level, it is horrible. I mean, they don't give you the good stuff. You know? Mm-hmm. So the other thing with Parkinson's disease, you know, Medicare decides which drugs you can use, and that definitely affects the quality of your life. You know, one of the best drugs on the market now, it's only symptomatic, is Rytary, which is time-release levodopa carbidopa, and works very well, but it's too expensive. There is no generic available. I last week I went on, well, beginning of this month, I turned 65 this month, and so I'm on full Medicare now, Part D drug prescription. So my prescription drugs and my Rytary went from $35 or $30 for 3 months supply to $910 for a 30-day supply. People, I mean, I can afford it, but I can't do a lot else. So, but most people cannot afford that, so they don't even prescribe it. Imbresia is another one. Rescue dose, I was paying $40 for that one. Now I pay $880. So that's, I mean, it's great examples of how the discrimination is. You know, I mean, people just can't get the drugs, and that's just not right.
But thank you so much. That it adds the
Yeah.
when you're thinking about the resources, and I presented it as resources that are available in a place, but then there's
Right.
the additional layer of what resources are available in a place that are accessible,
Right,
and how
exactly.
that also changes the conversation.
Exactly. So, yeah. And the one other quick point I want to make, you know, one thing we battle with trying to get neuropalliative care, started in our area, is people's perception of what neuropalliative care is. And I know we're talking about a broad range of diseases here, but neuropalliative care is not end-of-life care. And when we have discussions and we talk about end of life at the front end, I think that hurts us in the long run. I know I understand that you talk about feeding tubes and such things, but yeah. So if you have any comment on that, I'd be interested. So, yeah, I'm on the advocacy group with Melina, and that's been a battle for us, is trying to get them to understand. You know, I tell them it's like a square and a rectangle. So, yeah.
Yeah, I think, I mean, that's the ongoing theme. Thank you for bringing those things up. That's the ongoing themes of all that we're trying to solve in these days. I wonder, did anybody have anything specific for Christina Jess? Yeah. We want to, because we'll lose access to, direct access to Christina anyway. So, yeah. Christina can't see you, so Jess Bresbris from California has a microphone with a question for you.
Hi, Christina. Thank you so much for your talk. I'm curious, you started out, you mentioned how uncomfortable it was to have a patient talking to you and, doing Sudoku and sort of enjoying their life and engaging in society in one day and then being gone the next. I'm really interested in that, and I'm interested to hear your reflections on what was so, why that was so scary. We submitted a poster that was supposed to be presented at AHPM in 2020, and then obvious things happened about moral distress in the setting of awake extubations or awake discontinuations, because I think it speaks to our picture of what we expect dying to look like. and how we don't expect to be able to talk to someone and enjoy their presence and then have them be gone. We expect them to sort of fade away slowly or to not be present at the end. But at the same time, and we see this with awake extubations like in ALS, and we see this in medical aid in dying and other settings, it's the time we can be the most sure about what someone wants at that moment, right? When someone is intubated and unresponsive, we're making a lot of assumptions based on their prior statements and what we know about them. But when someone's awake on a ventilator asking us to stop it, we feel so much discomfort and distress, even though it's the most sure we can ever be that that discontinuation is in line with goals. So sorry, that's a long-winded way of saying that I'm really curious about how your gut reaction, like where you think that came from, that gut reaction of discomfort with awake discontinuation, and how that's changed as you've sort of thought about the ways we communicate this to people.
Thank you. Microphone.
Yeah. Okay, try again.
Can you hear me now?
Say again. Yeah.
Can you hear me?
Yeah.
Yeah. That's a really interesting question. I am not sure that I really know the answer to it, even for myself. I think there is something about causing someone's death in this. So because the two instances of you delivering or withdrawing a treatment which requires giving medications to manage symptoms and them dying is so causally time related, it feels as if you're involved in causing the death, whereas of course you're managing the symptoms and it's the motor neurone disease and their inability to adequately ventilate themselves because of the motor neurone disease that's the cause. And I understand that with my head, but the heart doesn't feel that. And I think that that is the root cause of it, but it feels as if I've done something that I shouldn't be doing. And in the UK, I guess that's partly tied up with physician-assisted suicide being not legal. But even if it was legal, I think that still is a very nuanced discussion about symptom management versus medications leading to death. And part of that is that there's a very different set of medications that one might use if one was deliberately trying to end someone's life and ensure that rather than managing their symptoms. But in some of the papers on withdrawal from other countries, there are some grayer areas about that intentionality. So I don't know why it's such a head-heart disconnect, but I think that's at the root of it. I don't know if you have any reflections on that that would be useful to me.
Thank you, Christina. Yeah, and thanks, Jess, for the question. I think this is a reminder of the really difficult space that we are in, difficult and important space that we are working in on a basis that's hard to explain to people outside of this world, right? We are dealing with these extremely difficult to answer questions, maybe not answerable questions, where we're just trying to find the best path with no answer all the time. And so because of that, we need to sustain ourselves and we should probably eat, right?
Yes.
Yeah.